melatonin. Dr. Hatta?
Yes. Good morning. Thank you for your kind introduction, and I'd like to express my thanks to Professor Claudia Spies and the Leopoldina for inviting me. This is my COI. Well, in this presentation, I'd like to address effects of melatonin on delirium prevention. First, I'm going to talk about regulating function of melatonin on sleep-wake cycle and mention clinical features and theories on the development of delirium. Then, I will focus on evidence for preventing effects of melatonin on delirium. After that, I will discuss other possible properties of melatonin associated with delirium prevention. Finally, I will present our latest findings of an orexin antagonist on delirium prevention. Okay, so I will start by talking about regulating function of melatonin on sleep-wake cycle. Melatonin is synthesized primarily in the pineal gland from tryptophan by way of serotonin. Melatonin has a variety of physiological functions, such as regulation of circadian rhythms, vasomotor responses, and sleep, retinal neuromodulation, inflammatory immune processes, and scavenging oxidative stress. Melatonin shows these functions by binding with various proteins, such as melatonin 1 and melatonin 2 receptors. Melatonin 1 receptor plays a role in acute inhibition of firing from the suprachiasmatic nucleus, and melatonin 2 receptors plays a role in primarily in phase-shifting effects on circadian rhythms. Nocturnal secretion is a major character of melatonin. Plasma melatonin begins to increase in the evening and reach its peak at around 2 a.m. And that promotes sleep with nocturnal hypotensive, vasodilating, and hypothermic action. A problem is decrease in nocturnal secretion of melatonin according to age. This line graph with high peak represents a young man at mean age of 24, whereas the line graph with low peak represents mean age of 68. There are a lot of hospitalized patients above the age of 80 whose regulation of circadian rhythms, vasomotor responses, and sleep must be blunted due to much lower peak of melatonin secretion. So I would like to emphasize the existence of such patients with vulnerable sleep-wake cycle in intensive care situation. Then I will mention clinical features and theories on the development of delirium. As you know, the fundamental concept of delirium is altered arousal and its fluctuation. Clinically, sleep-wake cycle fragmentation is core features, or one of the core features of delirium. So, therefore, The diurnal sleep melatonin dysregulation is considered one of theories on the development of delirium. Key points here are as follows. Age-related changes in melatonin rhythm cause decrease in nocturnal secretion of melatonin. This causes disturbed sleep-wake cycle that is a core feature of delirium. So, what happens when we supply melatonin to patients with risk factors of delirium? Now, I will focus on evidence for preventive effects of melatonin on delirium. This slide shows a list of placebo-controlled randomized clinical trials of melatonin effects on delirium prevention. You will notice that the incidence of delirium in the melatonin group was significantly lower than that in the placebo group in the trials by Dr. Sultan and Dr. Alama's trials. In the De Jong trial by De Jong, there was no significant difference in the incidence of delirium, but a smaller proportion of patients in the melatonin group experienced a long-lasting episode of delirium compared to the placebo group. So, melatonin appears to be effective in preventing delirium to some extent. What about Lamiltion? It's a drug for insomnia in Japan and the United States, and has 6 and 3-fold higher affinity for melatonin 1 and melatonin 2 receptor, respectively, than melatonin. So our clinical research question was whether Lamiltion would be more effective than melatonin in preventing delirium. Let me explain our research methods. We conducted a multi-center rater-blinded placebo-controlled randomized clinical trial in intensive care units and acute phase wards. Eligible patients were 65 to 89 years of age, newly admitted due to emergency, able to take medicine orally, and expected to stay 48 hours and more. Patients were assigned to Lamiltion placebo every night for 7 days. The main outcome measure was incidence of delirium according to DSM-4. This is a trial profile. 34 patients were allocated to placebo, and 33 patients were allocated to Lamiltion. This slide shows a comparison of baseline characteristics between groups. There is no significant difference in any items. Here we have scattergrams of the highest total score for delirium rating scale revised 95 in each patient. Patients taking Lamiltion developed delirium significantly less frequently than patients taking placebo. How about patients with dementia that is a major risk of delirium? Red diamonds represent patients with clinical dementia rating score 0.5 and more. Among such patients, the incidence of delirium was significantly lower than that in the placebo. How can we explain a better result of our Lamiltion study than that compared to the previous melatonin studies. One reason may be that ramiprotene has much higher affinity for melatonin 1 and melatonin 2 receptors. And another reason may be the dosage used. You can see the melatonin, considering these 2 points, the melatonin neurotransmission in our study was about 10-fold much more potent than that in Dr. Sultan's study, 100 more potent than that in Dr. Al-Ahmad's study, and 16-fold more potent than that in Dr. De Jong's study. Thus, a degree of promoting melatonin neurotransmission may be associated with delirium prevention. This slide shows other outcomes. There was no adverse events potentially attributable to the study drug. Unexpectedly, there was no significant difference in sleep parameters, any sleep parameters, even in disturbance of natural sleep-wake rhythm. So we should discuss other possible properties of melatonin associated with delirium prevention. First, I will mention neuroinflammation. That is a major theory of the development of delirium. This is Dr. Dillon and colleagues' study. They reported that patients with post-operative delirium showed significantly higher levels of C-reactive protein during perioperative period compared to patients without delirium. From the perspective of inflammation, I would like to draw your attention to tryptophan metabolism. Melatonin is produced from tryptophan through the METX-indole pathway. Neuroinflammation can activate the kynurenine pathway and produce not only neuroprotective but also neurotoxic metabolites. Consequently, the biosynthesis of melatonin decreases. Remarkably, Dr. Adams, Wilson, and colleagues examined the relationship between a kynurenine-tryptophan ratio and delirium coma-free days, and found the significant negative correlation. So what happens when we supply melatonin to patients with inflammation? This is Dr. Fink and colleagues' study. You can see survival rate after sepsis in rats. They reported that compared to VICU, administration of melatonin or ramiprotene significantly improved survival time. What is interesting is that this effect was completely antagonized by luzindol, that is a potent melatonin receptor antagonist. They also reported that melatonin, ramiprotene, and luzindol had no significant effect on survival time in melatonin 1 and melatonin 2 receptor knockout mice. Furthermore, prolongation of survival time by melatonin was dose-dependent. In this context, I will mention potent antioxidant ability of melatonin. Reduced levels of endogenous melatonin has been established in various conditions, such as ischemic brain disease and ischemic heart disease. Admission diagnosis of our Melatonin study were consistent with such conditions. So, supplying a melatonin agonist Lamiltion may have worked as a potent antioxidant and contributed to delirium prevention. I would like to go over the main point. Melatonin has effect on delirium prevention to some extent. We found more obvious effects of Lamiltion potent melatonin agonist on delirium prevention. Possible mechanisms are regulating sleep-wake cycle, regulating neuroinflammatory processes, and scavenging oxidative stress. Next, I will present our latest findings of an orexin antagonist on delirium prevention from the perspective of importance of improvement in sleep-wake cycle disturbance. This is a first presentation of this data. Orexin is a neuropeptide that maintains waking. Spirexant is a potent and selective orexin receptor antagonist that switches from wake to sleep. It's already approved as a medication against insomnia in Japan and the United States. Antagonizing the action of orexin can contribute to improvement of sleep-wake cycle disturbance. So we examined whether spirexant has effect on preventing delirium. Methods were almost the same as our previous Lamiltion study. Patients were randomly assigned to spirexant or placebo every night for 3 days. Here we have scattergrams of the highest total score for delirium rating scale, revised 98 in each patient. Patient taking spirexant developed delirium significantly less frequently than patient taking placebo. This slide shows changes in sleep-wake cycle disturbance score of delirium rating scale revised 98 in the spirexant group and placebo group. Another reviewed tendency for main effects of treatment that shows potential of spirexant to improve the circuiting core domain of delirium. So main points are these. Spirexant, a potent selective orexin antagonist, has effects on delirium prevention. This is further evidence for the importance of improvement in sleep-wake cycle disturbance about delirium prevention. Finally, I would like to mention how to use melatonin agonist Lamiltion in real practice as consultation liaison psychiatrists in Japan. We use this drug as the first choice for insomnia in patients with risk factors of delirium. We use it for prevention of delirium subsequent to delirium at the previous night in the oldest old. We use it for prevention of or treatment of delirium in patients with advanced age in combination with spirexant, gabapentin, or antipsychotics. A limitation is that it's available only for oral administration. I would like to conclude by making the following points. melatonin has effects on delirium prevention to some extent. Ramipril, a potent melatonin agonist, has more obvious effects on delirium prevention. Points of clinical usefulness are probably affinity for melatonin 1 and melatonin 2 receptors and dosage. From the perspective of sleep function and dysfunction, melatonin is not futile, but practical hope. That's all I have to say. Thank you very much for your attention.
Questions?
Time, or do you have a SOP for that? When do you use it?
Sorry?
When do you use it in both together?
I see. First, I give Ramipril about in the evening, 7 p.m., about 7 p.m. And when patient do not sleep at 9 a.m. or 10 a.m., I will give subarextant more. Yeah.
Thank you very much.
If there are no questions, I have a comment. Unfortunately, in Germany, no Ramipril and no suvorexant are available, as you know, maybe in other European countries also. But we have a new melatonin receptor agonist, maybe you know about tasimeltion. And tasimeltion has a higher affinity to the melatonin 2 receptor. So I suggest, if you get it also, your study design, you have to repeat also with tasimeltion.
Maybe the dose is very important because a lot of melatonin study, the dose is too low to reach effect. For example, the Ramipril, the commercial name is Rosarem, is 8 milligram tablet. 8 milligram Ramipril is equivalent to about 50 milligram melatonin. So maybe melatonin study need more dose to express.
So it's not only a question of the compound, but also on dosage. Yeah.
Very interesting talk. You mentioned that there is a prescription in Japan for insomnia. And does the drug have any tolerance induction, or what happens if you have an overdose? How do you have, what's your experience on that?
Tolerance. This drug is very there's almost no side effects. It's very safe. So it's suitable for preventing using. If the drug has side effects often, it's not for preventing use. So yeah. Subarexant and melatonin. In subarexant and melatonin, we seldom experience side effects. It's very merit of these drugs.
We took part in clinical phase 2 and 3 studies with Ramipril 8 milligram, and at least in the follow-up period of 3-6 months, we did not observe tolerance, but we do not know long-term data. No, it's not available. Where was one more question?
Okay, thank you for this talk. And I just want to ask if the intrinsic activity of Ramipril and melatonin is the same, since you say the affinity is higher.
Sorry?
The intrinsic activity, so the affinity to the receptor is the same, or it's higher for Ramipril. So if the intrinsic activity, if just attached to the receptor is the same for those both?
Melatonin and ramition.
And melatonin?
Melatonin and ramition.
Compare that, yeah.
Ramition is very selective for melatonin and melatonin-2 receptors. So maybe the melatonin has a wide range of effect, but I don't know. I don't know answer for your question.
Another short question. I heard the first time about suvorexant as an orexin antagonist. What happened to the eating behavior of these patients?
There's no effect on eating behaviors, at least our observation here.
Thank you.